Welcome to This Week in Anesthesiology. This week we're covering 9 notable papers spanning perioperative pharmacology, advanced clinical monitoring, and regional anesthesia optimization. Let's dive in. We begin with an important comparison of neuromuscular blockade reversal agents in the setting of upper gastrointestinal endoscopic procedures. This retrospective multicenter cohort study analyzed over 15,000 propensity score-matched patients to determine whether reversing rocuronium with sugammadex rather than neostigmine improves respiratory outcomes. Postoperative pulmonary complications are a major concern in these procedures, often exacerbated by residual neuromuscular block. The investigators defined their primary outcome as the failure of tracheal extubation, which meant postoperative ventilator dependence or tracheal reintubation within 30 days. The results revealed that extubation failure occurred in just under 4% of the sugammadex group, compared to nearly 6% in the neostigmine group, representing an absolute risk reduction of nearly 2% and a number needed to treat of 52. Furthermore, sugammadex was associated with a lower rate of lung atelectasis or collapse and fewer unplanned intensive care unit admissions. Notably, this respiratory benefit persisted even in the subgroup of patients without any pre-existing chronic pulmonary disease. This suggests that opting for sugammadex over neostigmine can yield clinically meaningful improvements in respiratory recovery, even for patients undergoing shorter endoscopic interventions. Moving to another common perioperative drug, we examine the metabolic effects of intraoperative dexamethasone in patients with diabetes mellitus. While a single 8 mg dose of dexamethasone is highly effective for preventing postoperative nausea and vomiting, clinicians often hesitate to use it in diabetic patients due to concerns over hyperglycemia and wound infections. Writing in the British Journal of Anesthesia, researchers conducted a pre-planned sub-study of the PADI trial, analyzing over 1,100 patients with diabetes and an hemoglobin A1C of less than 9%. They found that patients receiving dexamethasone had a modest increase in their maximum perioperative blood glucose levels within 24 hours of induction, reaching a median of 12.5 millimoles per liter compared to 10.3 millimoles per liter in the placebo group. However, this modest glycemic rise did not translate into an increased risk of surgical site infections, which occurred in 11% of the dexamethasone group and 14% of the placebo group. Additionally, there were no differences between the groups regarding the need for rescue insulin or the occurrence of hypoglycemic episodes. These findings provide strong reassurance that the benefits of dexamethasone for nausea prophylaxis outweigh the transient glycemic impact in this patient population. In a related exploration of metabolic modulation, a study in Science Translational Medicine investigated the translational potential of drug-induced hypothermia for acute ischemic stroke. Hibernating animals survive extreme conditions by lowering their body temperature and metabolic rate, and replicating this state could protect ischemic brain tissue. The researchers evaluated a combination of chlorpromazine and promethazine. In animal models, this drug combination successfully induced hypothermia, suppressed brain glucose metabolism, and reduced infarct volumes. They followed this with a double-blind Phase 1 clinical trial in 32 human patients with acute ischemic stroke. While lower doses were well tolerated, only the highest dose of 100 milligrams achieved a modest and transient reduction in body temperature. Plasma proteomic profiling confirmed a downregulation of markers associated with aerobic respiration and glucose metabolism. While larger trials are needed, this study establishes a safe, pharmacologically induced approach to metabolic suppression that could one day serve as a neuroprotective strategy. Next, we transition to regional anesthesia and the management of thoracic surgical pain. Video-assisted thoracoscopic surgery, or VATS, is widely performed but remains associated with significant postoperative pain. While thoracic paravertebral block is a guideline-recommended technique, intrathecal morphine is a technically simpler alternative. In a randomized, non-inferiority trial, researchers compared these two approaches in 72 adults undergoing elective VATS. The paravertebral block used 0.5% bupivacaine at 0.4 milliliters per kilogram with epinephrine, while the intrathecal morphine group received 5 micrograms per kilogram based on ideal body weight. The primary endpoint of 24-hour systemic morphine equivalence showed a median difference of 6.5 milligrams in the intention-to-treat analysis and 9.0 milligrams in the per-protocol analysis, both of which clearly favored the paravertebral block. The trial failed to demonstrate the non-inferiority of intrathecal morphine, as the upper confidence interval bound exceeded the pre-specified non-inferiority margin of 5.05 milligrams. Patients who received intrathecal morphine also required rescue analgesia more frequently. Although pain scores, quality of recovery, and safety profiles were similar between the groups, thoracic paravertebral blocks remain the superior choice for minimizing systemic opioid consumption after VATS. When discussing chronic and postoperative pain, precise terminology is essential. A conceptual article in the journal Pain addresses the widespread and often inaccurate use of the term central sensitization. The authors clarify that central sensitization refers to a specific neurophysiological state of increased nociceptive signaling within the central nervous system, and it should not be used as a catch-all label for any unexplained chronic pain condition. Maintaining diagnostic precision is critical for guiding appropriate therapeutic interventions and ensuring clear communication in clinical research. Monitoring technology is also evolving rapidly to provide non-invasive alternatives to traditional arterial lines. A review article in Anesthesiology outlines the current landscape of non-invasive arterial pressure monitoring during anesthesia. The authors discuss how continuous, non-invasive technologies are bridging the gap between intermittent blood pressure cuffs and invasive arterial lines, offering clinicians real-time hemodynamic data while avoiding the risks of arterial cannulation. In the realm of advanced hemodynamic assessment, portal vein Doppler ultrasound is gaining attention in perioperative and critical care medicine. A narrative review in the European Journal of Anesthesiology details how bedside portal vein Doppler can help evaluate venous congestion. By measuring portal flow characteristics such as pulsatility and diameter, clinicians can gain insights into right ventricular function and systemic venous compliance. However, the authors caution that the current evidence supporting this technique is predominantly observational. While portal vein Doppler is a valuable physiological tool, prospective clinical trials are necessary before portal flow guided algorithms can be recommended for routine, daily practice. Meanwhile, managing ventilation in pediatric patients often requires frequent invasive arterial blood gas sampling. To address this, researchers publishing in Anesthesiology developed a machine learning model to estimate arterial carbon dioxide partial pressure using non-invasive end-tidal carbon dioxide levels and routine clinical data. Utilizing over 8,000 paired measurements from the VitalDB database, they trained a gradient boosting model. The model performed exceptionally well, achieving a mean absolute error of just 2.73 millimeters of mercury. External validation confirmed its stability and generalizability. Interestingly, the model's accuracy relied heavily not just on end-tidal carbon dioxide, but also on body temperature, fraction of inspired oxygen, and preoperative hemoglobin. This machine learning approach offers a promising path toward high-fidelity, non-invasive ventilatory monitoring in children. Finally, we turn to a common clinical concern in transfusion medicine: the relationship between blood transfusions and venous thromboembolism. While historical observational data suggests that allogeneic red blood cell transfusions significantly increase the risk of postoperative venous thromboembolism, these studies often failed to account for key confounding variables. To resolve this, a retrospective cohort study of over 83,000 patients undergoing major surgery was. In the unadjusted analysis, red blood cell transfusion was associated with a 5-fold increase in thromboembolic risk. However, after the researchers adjusted for 37 clinical confounders, including anemia, blood loss, and the administration of other blood products, the association disappeared entirely, yielding a non-significant odds ratio of 1.02. Interestingly, the study did identify a significant, independent association between fresh frozen plasma transfusion and an increased risk of postoperative venous thromboembolism, with an adjusted odds ratio of 1.33. This suggests that the red blood cells themselves may not be the driver of thromboembolic risk, but rather the underlying surgical pathology and the administration of procoagulant blood products like fresh frozen plasma. If you only have time for one paper this week, make it the PATI trial sub-study on dexamethasone in patients with diabetes from the British Journal of Anesthesia. This paper provides robust reassurance that a single dose of dexamethasone causes only a modest, transient rise in blood glucose and does not increase surgical site infections, removing a common clinical barrier to optimal postoperative nausea and vomiting prophylaxis. Here are the key takeaways from this week in anesthesiology. First, when reversing neuromuscular blockade after upper gastrointestinal endoscopies, sugammadex significantly reduces postoperative pulmonary complications, including extubation failure and atelectasis, compared to neostigmine. Second, for video-assisted thoracoscopic surgery, intrathecal morphine is not non-inferior to thoracic paravertebral block, as paravertebral blocks achieve significantly lower systemic opioid requirements. Third, the historical association between red blood cell transfusions and postoperative venous thromboembolism appears to be driven by confounding factors, though fresh frozen plasma transfusion remains independently associated with increased thromboembolic risk. Fourth, machine learning models incorporating parameters like body temperature and fraction of inspired oxygen can accurately estimate arterial carbon dioxide from end-tidal measurements in pediatric patients. Finally, portal vein Doppler ultrasound offers a promising physiological window into venous congestion, but clinical algorithms still require prospective validation before routine bedside implementation. That's your roundup for this week in anesthesiology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.